I was asked to deliver a lecture on subaxial cervical spine anatomy, and that's what I will try to do now. So basically, this is the so familiar double S-shaped curvature of the spinal column, and we have discussed with somebody of you that this is very important for bearing the eccentric movements that the spinal column has to bear every day in all our activities. So we are going to focus now on the that portion here, the subaxial cervical spine. So in general, the cervical spine is the most mobile portion of your spine, and it has a lordotic configuration, the greatest range of motion, and if it's very mobile, then it is more vulnerable to injury. If something is mobile, then it's unstable, and vice versa. So this is the typical shape of a cervical subaxial spinal vertebra, and you could discriminate here the body, and then the pedicles, as usually the lamina, and then you can see the superior and the inferior articulating process, and then the articular pillar. And all this structure here, as you know, and probably most of you is familiar, is called lateral mass, and the anatomy of lateral mass is very important for the everyday practice. You normally put your lateral mass screws here. Another particularity of the cervical spinal vertebrae are the oncovertebral joints, which are also important for the stability and for the movement, specific movement of the cervical spinal cord. That's an important landmark when you do anterior foraminotomies. You could compare now the shape of the vertebrae. You can see that in each section of your spine, the vertebrae, they have a specific shape and specific form. And you could, if you're familiar with the spinal vertebrae, you could easily discriminate that a vertebra is coming from cervical, from thoracic, or from the lumbar part of it. It's a table that compares the most characteristic features of the vertebrae that are coming from different parts of your spine. So for the cervical spine, the typical characteristic is that body is usually small. It's missing obviously at C1 and then grows from C2 downwards. So the transverse process is short if compared to the rest of your spine, and normally you will see the transverse foramen down to C6 in the majority of the cases, but that's not 100%. You can see transverse foramen also in C7 in about 5%, I think, of the cases, and this will have the vertebral artery. Spinous process short, and except for C7, which is actually quite long, and it's a landmark when you try to tailor your approach in your skin incision. So the supporting ligaments are equally important as the bone for the stability of the cervical spine. Very strong. It starts from is to prevent hyperflexion. It's a major contributor for the stability of the cervical spine. Moving down to posterior longitudinal ligament, it is weaker if compared to the anterior longitudinal ligament, but it is also a good stabilizer, prevents hyperflexion. Again, attaches to the intervertebral discs, and you will see it running from the from top to bottom of your spinal canal. Ligamentum flavum, one of the most of the strongest ligaments. It's basically lining the canal from posteriorly, lamina to lamina, and it is a major contributor for the stability as well. Protects neural elements, stabilizes, and forms the posterior wall of the spinal canal. It will stretch when the cervical spine is flexing, and it will buckle when the cervical spine is extending. And if the canal is narrow, this is a major contributor for the stenosis of the spinal canal in the cervical section, and in many cases will cause problems and will be a contributor for the myelomalacia. Intertransverse ligaments. Intertransverse ligaments, they are not very well developed in the cervical spine, so we're not going to talk a lot for those with regards to the cervical. However, interspinal ligaments together with the supraspinous ligaments, again, another major contributor for the stability of the cervical portion of your spine, and actually this is part of the tension bands that has a great importance for the functioning of the cervical spinal column. We said about that. So facet joints, another important ligamentous structure, contributors for the range of movement. It's a weight-bearing element. It's a synovial joint. That's what we're talking about. And again, big importance for the stability. That's a good picture that I put here just to corroborate the anatomy with the radiographic anatomy. So you could see the correlation here. But when I was doing my presentation, actually, I realized that this picture is wrong because this is somebody other. So what's wrong with this picture? You can see the nerves, they're quite high here. That's about right here now. So you can see that the nerves are running down here because it's silicone, it's springing up. And so this is important to know because basically this is the anatomy that you should know when you're putting your lateral mass screws. That's why you go up and laterally, up to avoid the nerve and then laterally to avoid the vertebra. So, important concept, the functional unit. This is basically considered to be two adjacent vertebrae together with the disc and with the ligamentous complex. And this is the basic functional unit of the spine. And it has, this concept has importance for you to understand the biomechanics. If we go to the biomechanics of the lumbar spine, we can see that the majority of the forces are being distributed in the posterior, in the anterior column and then the mid column mainly, and only 10–20% go through the posterior column. However, it is completely the opposite in the cervical spine. You can see that the majority of the forces go through the posterior column here. The intervertebral disc, equally important for the stability of your spine and also for the normal functioning. 23 intervertebral discs. You should consider that there is no C1, C2 disc. I have seen a radiology report C1, C2 disc herniation, so that's funny. So you have to be aware with that. Discs are contributing for the height of the spinal column, and they are major shock absorber. They allow spine to bend, and it is also allowing the even distribution of the forces, the axial loads. This is the anatomy of the disc. You have the annulus fibrosus and the nucleus pulposus. So the nucleus is inside, is gelatinous matter that acts like a rubber ball, and is comprised of 60–70% water in the young people. But with age, this percentage goes down, and this is part of the degeneration process. The annulus fibrosus, very strong, and you can see that the fibers are crossing. The different lamellae have different the different direction of the fibers, and this contributes for the stability and for good strength of the annulus. So collectively, the discs make about 25% of the height of the vertebral column, and we said that the nucleus pulposus becomes dehydrated during the day and also with age, and this is a major contribution for decreased range of motion and narrowing of the intervertebral foramen, and basically major part of the trigger of the degeneration process. And this is what happens when the degenerative process goes on. With the dehydration, your disc will collapse, and then this will cause more work and more weight bearing for the posterior column, and then the posterior column elements will hypertrophy, and then you'll see narrowing of the intervertebral foramina. You will see also buckling of the ligaments. You will see osteophyte formation, and this will result in a narrow canal and all the problems because of that. And this will result in finally this shape for all of us. This is the pathomechanism of the degenerated disc. You see, with the decreasing of water in the nucleus pulposus, we have a loss of tension of the fibers of the nucleus pulposus, and this will cause more lateral and rotational instability, and then this will cause unphysiological weight bearing, and then cumulative damage of all the adjacent structures, and finally degenerative process. That's the degenerative process, degenerative disc disease features: annular tears, reduced disc height, bulging of the annulus fibrosus, end plate fractures, disc herniation, and arthritic changes in the zygote joints and osteophyte formation. And that's probably the biggest importance, and that's the anatomy that you will normally see in your everyday life. You will not see the normal anatomy. The majority of the people will present to you with this anatomy. Thank you.